Hi, this is chapter 24 of the MDA book, Dental Unit Waterlines. The presence of bacteria in dental unit waterlines was reported more than 30 years ago. So outbreaks of waterborne diseases have occurred in a broad range of facilities, including hospitals, nursing homes, schools, restaurants, and community water supplies like swimming pools and spas. Although there's no evidence that suggests a widespread public health problem, there have been published reports of illnesses associated with exposure to water from dental units. There is bacteria capable of causing disease that can be detected in dental unit water lines, which is a reason for concern. So we need to be flushing and cleaning these water lines as recommended by the manufacturer, because that bacteria is capable of causing disease in humans that is found in these water lines. So in community water, the number of waterborne bacteria is kept below 500 CFUs or colony forming units. And the type of bacteria found in dental unit water are frequently the same as those found in community water. But the quantity of bacteria found in the dental units is noticeably higher. So when we analyze water from air water syringes and dental handpieces, repeatedly the levels are hundreds or even thousands of times greater than are the amount in the permissible drinking water. So because the primary source of those microorganisms in the dental unit water lines is the public water supply, we have to make sure that we are, again, cleaning those lines appropriately. Saliva can be retracted into the dental unit water lines during treatment of a patient, and that is called backflow. So with that backflow, the saliva is brought back into the lines, and they put anti-retraction valves on these units so that it minimizes the chances of the patients getting anything like suck back in their mouths from this. And what that is when the patients are using like a saliva ejector, if they close their mouth around the saliva ejector and keep it closed, it creates a vacuum. With that vacuum, instead of it sucking everything out of their mouth, it can cause a suck back and actually create a vacuum and bring things back into their mouth from the line. So you never want to have your patients closing their lips around the saliva ejector because of that suck back that it can bring. So I know that probably all or most of you have been to the dentist and they've told you close your lips around this straw or this saliva ejector. You can do that quickly, but you never want to leave it around there and be sucking on that saliva ejector because it does create that suck back. And with that suck back, it can give you the chance of drawing in fluids from what's inside of those lines. So there are two communities of bacteria in the dental unit water lines. The two different kinds are planktonic, which planktonic is a free-floating bacteria. It is actually found in the water itself. So like if you were to look at water and you can see the slimy stuff floating on the water, that is planktonic or free-floating bacteria. The biofilm microbes attach to the inside walls of the dental unit water lines. So those are the two different kinds of the biofilms. So the biofilm that attaches to the inside of the dental unit water lines are like if you were to have a little baby swimming pool with no filter on it outside in the summertime and fill it up and leave the water in it for a few days, and it still looks like it's clean out in the sun, but you get in it and it feels slimy. That slimy feeling is the biofilm, not not being able, not the free floating what's on top, but what is attached to the walls of the pool. So those are your two kinds of bacteria or microorganisms that we're looking at in the water lines. So biofilm forms when bacteria adhere to surfaces exposed to water and they begin to excrete a slimy glue-like substance. The biofilm itself exists in all places where moisture and suitable solid surface are found, and it consists of bacterial cells and other microbes that adhere to a surface and form a protective slime layer. So biofilm is going to have different types of bacteria. It's not just one type of bacteria, and it also will have fungi, algae, and protozoa in it. It can also have viruses like HIV virus, but things like the HIV virus cannot multiply in dental unit water lines. So make sure that you note that. So things that promote growth in the dental unit water lines is that the water moves slowly. So as it moves slowly, it does promote the growth because it's not flushing it out of the lines. And then because there is intermittent stagnation, meaning that the water isn't moving at all at times, when the units are not being used, it allows it to attach to the walls of the tubes inside. The bacteria then stabilizes and is fed by the nutrients that are in the water. Some offices even have water heaters that is made for patient comfort, is what they're designed for, so that the water isn't so cold when it's sprayed into the patient's mouth. But on the flip side of that is that the water heaters promote bacterial growth. With bacterial characteristics, once they're embedded in biofilm, bacteria is very hard to kill. They're 1,500 times more resistant to germicide than the free floating bacteria or the planktonic bacteria. So ways that we can reduce bacterial contamination is, it's not yet to eliminate the biofilm, but we can reduce it and minimize it with the use of self-contained water reservoirs. So instead of having the water supplied to our dental units straight from the public water supply, what we can do is have self-contained water reservoirs where they're filled with distilled water, and then only distilled water is delivered to the patient. That cuts down on some of the microorganisms that are delivered through the water lines. Also using microfiltration cartridges. The microfiltration cartridges will also help to reduce in the amount of bacteria that is delivered through the water lines, and the chemical agents. So with the chemical agents, those can be the blue tab water tabs that are put into the bottles, and they're designed to stay in the water as it's being used in the patient's mouth, and that helps to neutralize anything that's in the water. And reduce bacterial contamination. And then we also have our things like the weekly line cleaners that we can use so that it will kill the bacteria that is in the lines, or reduce. It's not going to completely kill. It's not going to get rid of the bacteria that's in the lines or the biofilm that's in the lines, but it is going to reduce the amount that is in there. So with dental unit water should not be used as an irrigant for surgery. if you're involving the exposure of bone. The only water that should be used if you are involving the exposure of bone is sterile water from a special sterile water delivery system or a hand irrigation system with sterile water in a sterile disposable syringe. It's very important that only sterile water is used during surgery involving bone. Procedures such as periodontal surgery, root canals, and tooth extractions are riskier because they expose the gum line. Introducing dental unit water could also introduce disease-causing bacteria. All dental unit water lines, or DUWLs, and handpieces should be flushed in the mornings and between patients. So flushing them is taking them out of their holder and allowing water to run through them for 30 seconds. So you do that in the morning before you see a patient, and then after each patient, you allow it to flush for 30 seconds. And not only the line, but the handpiece that you used. And that's important because tooth fragments and filling materials can get stuck in the heads of the handpieces, and you want to be able to flush those out prior to cleaning and sterilizing them, because you don't want to put them into the autoclave and sterilize them with the tooth fragment stuck in there, because then when it comes out and it still has that tooth fragment in there, it's not completely sterilized. I mean, it is, but it has a tooth fragment in it. So really it's not sterilized because it's not in the state that it should be in. Also, it will help clean the handpiece water lines of materials that may have entered, like from the patient's mouth, like I said, the filling materials, and flushing brings a fresh supply of chlorinated water from the main lines into the dental unit. Always use a high volume evacuator, so the HVE when using the high-speed handpiece, ultrasonic scaler, or the air water syringe. So anytime that a tooth fragment or a filling material or lots of water is going to be used, you should be using your HVE. So most of the time, that is the suction that you'll be using is your HVE. Very little of the time will you be using your saliva ejector. The high volume evacuator can also reduce the exposure of the patient to the waterborne microorganisms. So because it reduces aerosol and spatter from the patient's saliva and the water spray, it picks up big pieces of materials, it picks up tooth fragments. So the HVE is what we should be using as an assistant for our suction. Also, if your doctor uses a dental dam, that will greatly reduce the direct contact of the dental unit water lines and the microbes with the tooth that they are working on. It reduces the aerosolization and the spattering of the patient's microorganisms onto the dental dam. These protective barriers that we use, including masks, eyewear, and face shields, also serve as barriers for the dental team. Use water that meets the EPA's regulatory standards for drinking water. So when you are working on a patient, the dental unit water should meet the same standards as the Environmental Protection Agency's standards for drinking water. You should maintain recommended quality of dental water per manufacturer's methods. So if it's not drinking water, it should be distilled water. Monitor the water according to the manufacturer's recommendations and use commercial testing or in-office test kits. Always discharge the water and air for 20 to 30 seconds from any device after each patient treatment. And with backflow from low volume saliva ejectors, like I talked about earlier, this occurs when the pressure in the patient's mouth is less than that in the evacuator. When a patient closes his or her lips around the tip of the saliva ejector, a partial vacuum is created, which can cause backflow. That's a potential source of cross-contamination. That's when the patient can close around the saliva ejector and it can create a vacuum and it can draw things back from inside of the tubing into the patient's mouth. We do not ever want that to happen. So you're not ever going to ask your patient to close and keep their lips closed around that straw. They can quickly close around the straw, or you will suction with your large evacuator, your HVE, anything that you want removed from your patient's mouth. Thank you.